Good evening, and welcome to our Methodist DeBakey Cardiovascular Journal webcast. I'm Mike Quiñones. I'm the editor-in-chief of the journal and past chairman of the Department of Cardiology at Houston Methodist. The current issue of the journal is dedicated to the topic of cardio-oncology. We chose this topic because we feel that it's a very important area to update clinicians in practice due to the fact that so many patients with malignancies are now living longer because of the success of the therapies we use for cancer. However, some of these therapies can be cardiotoxic, and these patients either acutely or long-term can develop complications. So the sooner we get cardiologists and oncologists working together to diagnose, prevent, and treat these complications, the longer our patients will enjoy good health, both from being free of cancer and also being free of heart disease. I'm joined today by an excellent panel. They were all contributors to the articles in the journal. And on my left is Dr. Barry Trachtenberg. He is associate co-director of the he's director of cardiac oncology and cardiac amyloidosis program here at Houston Methodist, and assistant professor of medicine. Next to him is Dr. Eric Bernicker, associate professor of clinical medicine in oncology, and the Diane Harkin Modest clinical academic scholar at Houston Methodist. And Dr. Juan Lopez-Mattei, who is a cardiologist and the director of cardiac radiology services for the Department of Cardiology and Radiology at the University of Texas MD Anderson Center. They're all experts in the field. They all have contributed to the journal and also have their own research in the areas. And I'm delighted to be with them today. And without any further delay, I will pass it to Dr. Trachtenberg. However, it's important to remind the audience that you may have questions as you watch the webcast. So if you do, please feel free to text your questions and we'll try to address them. And text them to DeBakey to 37607. So you text DeBakey to 37607. Barry?
Thank you, Dr. Quiñones. It's great to be here, and I'm looking forward to a great discussion and a lot of things for us to discuss today. I think we'll start with a case. This is a case of a 44-year-old woman who came to Cardio-Oncology clinic a few months ago. So she was originally presented to the hospital with progressive shortness of breath, was seen in the ER a month prior, was diagnosed with bronchitis, sent home, continued to have shortness of breath, and was so short of breath that she could barely walk inside her house, and came to the hospital and was diagnosed with idiopathic cardiomyopathy. Had an ejection fraction that we'll see in a moment, severely depressed ejection fraction, and was seen by cardiology and was told that she had probably an idiopathic dilated cardiomyopathy after she had a negative myocardial perfusion scan. She was started on an ACE inhibitor and was sent home, and it turns out there was further history that she had had breast cancer greater than 10 years prior out of state, was treated with adriamycin, 4 cycles plus cyclophosphamide, Taxol, followed by 5 years of hormone therapy, and also had a mastectomy. And it didn't sit well with her that she was told she had this idiopathic cardiomyopathy, and she actually came to our cardio-oncology clinic because she kind of figured it out that it might be related to her chemotherapy. So this is her original echocardiography, and you can see she's got a severely depressed ejection fraction. EF, it was reported to be less than 20%. And I think this case, it really just highlights the need for this field, which is, awareness is increasing. We have a journal that we're discussing. There's 2 journals now that are devoted to cardio-oncology. But not everyone reads the journals. There's still a lot of
that's true.
A lot of people, cardiologists, oncologists, community doctors that aren't aware about this. So I think this highlights that. And I don't know, Eric, if you can maybe discuss a little bit about where we are with cancer survivorship in 2020.
Sure. Thank you.
Yeah, there's no question that we have not done the best job in oncology in terms of dealing with the whole issue of survivorship. So early on, the answer or the reason for that was clear. A lot of times our therapies were poor and patients did not do that well. With the advent of better therapies, both better screening, earlier detection, and then better treatment for advanced disease, so immunotherapy, better chemotherapy. The good news is more and more patients are surviving, but there's no question that we need to do a better job. Now, I'll be honest, a lot of times when patients are first diagnosed, they're so overwhelmed with the diagnosis and the implication, and when you start talking about chemotherapy or radiation and surgery, talking about late downstream toxicity is, I'm not saying it's not important because it's very important, but there's such a explosion of information that they're trying to internalize. All of our therapies can certainly cause acute effects, which when people think about chemo, that's what they, hair loss, nausea, and vomiting, but there's long-term side effects as well, endocrine, fertility, neurological, and we've got to do such a better job with survivorship. I think the other thing that we really also need to do a better job and work with our cardiology colleagues is that while smoking rates have declined, there still are a lot of smokers, and sometimes when patients end up with cancers that are not smoking related, colon cancer, prostate cancer, we don't do the best job at convincing them for smoking cessation. So smoking cessation needs to still be a major push, both for oncologists but also cardiologists, just to avoid the secondary development of coronary disease later.
Yeah, I mean, I couldn't agree more. The situation is that when you have a patient that have undergone all this cardiotoxic chemotherapy or have been exposed to radiation and all that, that part, when the cancer is done and we celebrate with the patient, we're so happy about it, but we have to also focus on what's going to happen next, what is going to be the most likely situation, and if they're on remission, the most likely situation will be that they will die of cardiovascular disease, and the rates of the survivors when you compare to a normal population are exceedingly high. So we have to definitely work together as cardiologists and oncologists and really take care of the patient and practice in a multidisciplinary care fashion so we can address those needs.
Absolutely.
So this patient appears to have come in a little bit too late, 10, 11 years later. So were you still able to help her?
So yeah, it's a great question. So there is some data that from Italy that shows, if you treat patients more than 6 months after their cardiomyopathy or cardiotoxicity is diagnosed, the chance of improvement is very minuscule. But I found that data to not always be true. So we put this patient on aggressive medical therapy. This is her echo after 4 months of optimization. And you can see it's significantly better. Not normal, but
no, it's not normal,
but
it
close.
looks better.
But 40-45%, and was able to not have to have a defibrillator, and now her survival prognosis is much better for her. So
it's fantastic.
So I think it is a case that shows us that we can treat patients late and we can have
great
outcomes.
outcome. Yeah.
So and we don't always have those outcomes, but
Right.
this is a good example of when we can have that outcome. And just so we do know that this field was started with anthracyclines, and this is still one of the most common chemotherapeutic classes of agents that is used. So it's still important to discuss it and be aware of it, even though the field has grown so much more beyond just anthracyclines. But I think our first article, by Dr. Anna Barak and colleagues from MedStar, did discuss anthracyclines and other therapies and their relationship to heart failure. And so I think it's important to highlight that with anthracyclines, that the dose matters, but it's not. But you can still get cardiotoxicity even at low doses. And if you look at this slide here, looking at even doses less than 250, there's still a reasonably high incidence of cardiotoxicity. So we know that the older data showed us that we can have symptomatic heart failure in about 1 to 5% of patients treated with anthracyclines, but subclinical cardiotoxicity all over the map, anywhere from 3 to 26%, depending on which study, depending on how it's conducted. I think a lot of that data was based on retrospective, not really prospectively getting echoes on these patients and following them. There is more contemporary data from the same Italian group, from Daniele Cardinale's group, and this is a study that over 3,000 patients with breast cancer and hematological cancers, and they followed them prospectively for years, and they looked at the very typical definition of cardiotoxicity, EF dropping less than 50% and by more than 10% from baseline. And it showed 9% of patients had cardiotoxicity, and these were patients that were excluded from concomitant HER2 antagonists, excluded high-dose anthracycline. So 9% of patients, and also about 9% of patients with breast cancer with a
very significant incidence. No one will get in an airplane with a 9% chance of crashing.
Absolutely,
that's true.
That's true.
And I should just point out, with these folks, with most of these patients with hematological malignancies or breast cancer, these are younger patients,
yes.
right? So this is not necessarily stuff that's being given in the palliative setting, which is why it's even more devastating a lot of times. Correct. When they're cured and then they develop this secondary health issue.
What I like about Dr. Cardinale's study, the one that you're referring to, the most recent one, I think it was 2015.
Yes.
And basically is that time matters. Like if you wait too much, and this is what she's shown, that basically more than 3 months, the patients tend to recover less fully. But it's important to address this and be proactive. And of course, there's some patients that are going to present later, and you still have to give them guideline-directed medical therapy. But in patients that receive anthracycline and they have a drop, that's why we have to monitor them. Time matters, and I think it's important also to highlight that part.
Absolutely, and I think another point that you bring up is the early toxicity. So in this study, it was for over 5 years, 98% of the patients that had cardiotoxicity had it within the first year. Correct. And that was really eye-opening compared to the literature we've always gone by, which is mainly retrospective and kind of diagnosing them after the fact.
Yep.
So I think that's a really important point. So Juan, these, maybe if you can, these are the American Society of Clinical Oncology guidelines. Maybe if you have any kind of highlights from these guidelines.
Sure. So, basically, the important thing is to identify the high-risk patient. Who this high-risk patient is really the cornerstone of really developing efforts to screen these patients and monitor these patients more effectively, because at some point after a year of treatment, as you well stated with how the data of Dr. Cardinale and others have shown that basically after a year the incidence will be way less. So that's why high risk, defining what is high risk matter. And older age, more than 60 years, basically also depending on the dose. Patients that receive more than 250 milligrams per meter square of adriamycin or 600 milligrams more from epirubicin. All of that, radiation therapy, more than 30 grays. It's very important to consider all this risk, and this the authors did a great work in illustrating what are the important points and what differentiate a low risk patient from a high risk patient. Yeah,
and I think it's really important, as you mentioned, older age. So even if you have a lower dose anthracycline,
correct,
just being over 60 is considered as someone at higher risk based on that.
And following that thought, it kind of reminded me something that I recently read about the double hit hypothesis, of which in patients, some people have proposed that perhaps this cardiotoxicity related to anthracyclines could be more like a double hit, because of risk factors. So patients already have some sort of risk factors for heart failure. But then at the same time, when they have either they receive or have received anthracycline, then perhaps that makes them a higher risk.
Yeah, and I think that's a very important point, because the more we have done good epidemiology in cardiovascular disease and in cancer, we're finding that frequently they are the same risk factors.
Yeah.
Yeah.
Obesity is a risk factor for both.
That's right.
Even diabetes is a risk factor for both, of course, smoking. So these patients come in to the oncologist with a malignancy, and guess what? They have a whole list of risk factors also for cardiovascular disease that may potentially make them more at risk for toxicity when they get their therapies.
Yeah, and another
that's a very important point to remember. Yeah.
And another point, in terms of risk factors, I mean, there's the study that we were very interested in because we were looking at this too. But Christine Seidman from Harvard and with other colleagues looked at genetic risk factors for the same genes that cause dilated cardiomyopathy in patients that had cardiotoxicity. I think 12% of them had truncating variants in TTN, which is the most common cause of dilated cardiomyopathy. So there are certainly, the Twohit hypothesis for at least some of these patients is real, and we're only beginning to learn the tip of the iceberg about that.
Believe me, I can talk here for hours about this topic, but all I'm gonna just mention is Marielle Scherer-Crosby from Penn. She did a very nice retrospective study, but it was very good about patients that receive anthracycline, and these were all acute leukemias. And what she found was that patients that had baseline abnormal strain, basically that having a baseline abnormal strain, global longitudinal strain, predicted development of acute heart failure. So it's very important to understand that all this follows this double hit or hypothesis.
Absolutely. So Juan, I know you and your colleagues with Dr. Alga being the first author, wrote the paper for the journal on how to screen and identify biomarkers and imaging findings for screening for cardiotoxicity. So maybe you can walk us through some of the highlights.
Sure. So basically, this table we prepared thinking about the different statements, consensus statements, and quote-unquote guidelines about how we should screen with imaging patients that receive anthracycline and trastuzumab. And in the 80s, basically, there was a lot of literature using MOGA. And the problem with MOGA is that every time you repeat a MOGA, you're exposing the patient to radiation. So I mean, all the accuracy and all that MOGA provides, but that's a really big limitation. So we abide more to use echocardiography, and basically the ESC and the ASC EICV. The both consensus statements are very good and give good guidance, and also recommend the use of global longitudinal strain. And ASCO has some, also they provided some sort of guidance about how to monitor. And I think as we go and move further along, we're going to have more data, and we're going to be able to give a more precise recommendation, not only just based on what the patient is receiving, but their cardiovascular risk. And
we may want to share with the audience that in those early guidelines, even before the availability of global longitudinal strain, we were using EF, ejection fraction. And we were talking about a drop of 10% or more, or less than 50%. Now, with more sophisticated techniques, even a drop of 5% is an important drop. And if we're honest, the reason we use 10% is because the variability of echocardiography in an individual patient is between 5 and 10%. So if you actually drop 10% or more, there was a very good chance that it was a real drop and not variability. The noise in the data. But now, if people that have used, for example, cardiac MRI, they have shown that even a drop of 5% probably is a significant drop. And of course, now we have strain, which can even give us a little earlier signal that there may be something. And
the variability of GLS is less than biplane echocardiography. And also the important point here is that a 5% drop could be significant if you use cardiac MRI, really, because by cardiac MRI the variability is like 2.5%.
Correct.
In comparison with biplane, which is going to be 5 to 6%. Right. So the 5% drop, using echo, I always have found it a little bit questionable, but certainly some patients will have symptoms with some minimal changes, perhaps. Is that that variability comes into play, but you can kind of polish it a little bit more with the MRI.
So, I mean, Juan, any comments briefly about biomarkers?
Oh yeah, of course. So basically, what I can tell you is that troponins. I mean, there have been several assays that have been looking into how we can predict cardiovascular adverse events during treatment with anthracycline toxicity and also trastuzumab. The main thing I will say is that the high sensitive assays, if you look at the table, have not proven to be that good in predicting adverse outcomes. The troponin I has been consistently biomarker, I would say, that has performed better, the best, and mainly with Dr. Cardinale's data. And also, it was something interesting is that Dr. Bonnie Key, she found in one of her many studies of the different biomarkers that the myeloperoxidase perform well in predicted cardiotoxicity, and perhaps it'll be interesting to see what the data shows us eventually.
Yeah.
I'd like to come back to this and get your comments on this, because obviously echocardiography, global strain, that sounds like high tech. And it's possible that in some communities they may not have all that high tech. Everybody can do a troponin I. And the last time I reviewed the data, I was confused as to really is troponin I inferior to echo, or are they complementary? So what's your opinion on that? I have not yet seen, and if there is, bring it up, because
Sure.
it's important. I have not seen a study where they have tracked them both and really give more clarity on which of the two might be more helpful. Because if troponin I has a fair amount of sensitivity and provides a good signal, it's a simpler test than an echo. So I like your comments.
Sure. So I can tell you that I can say what we do in our institution, this is why we need guidelines, right? We don't monitor the patient with troponin because, and we have data. We're working on a manuscript, but we presented some data recently at ACC last year, where what we show is that 10% of patients in the whole MD Anderson cohort, outpatient, inpatient, ER, 10% of patients will have troponin I, elevation in troponin I, without really having an explanation on why it is, meaning that not related to MI. So just that, there's a lot of noise with the troponin, and when you're in a in a large center, you guys also see this, all these patients with positive troponin, and sometimes you're like, well, this is either a type 2 MI or just mismatch. So I think these are the same issues. However, in the patient that is in the outpatient setting, if you have a positive troponin I, maybe that's something that you have to take more seriously. But what we do is we just monitor with echocardiography, and in our lab, our lower limit of normal is less than 50%. So we're a little bit more generous than the 53% per ASE. So I think that's what we use. I'm not saying this is the best, but this is what we use, and we feel that in doing that, we don't feel that we're precluding many patients in receiving life-saving chemotherapy, because there's a balance, right?
So it's fair to say that this is work in progress.
Yeah, I would say.
So, I mean, to be honest,
Barry, how do we do it here?
So we do. So it's a great question, and it's because the evidence.
It's work in progress.
It's a work. We do in our cardio-oncology clinic. If patients are at a little bit higher risk, we will do troponin serially to monitor them. And I'm not saying it's the right answer, because I think, as Juan mentioned, we really don't know. Yeah. But there is data to show that high-risk patients with the positive troponin, that if you randomize them to an ACE inhibitor versus control, the ACE inhibitor group preserves their ejection fraction, where a significant portion of the control group drops their ejection fraction. So I think at least in high-risk patients, there's evidence. But then the time, which assay, which timing.
So we'll be talking of therapy in a minute, but is it fair then to say that you use echo and troponin I?
Absolutely, yeah.
So you decide to intervene when either one of them gives you a signal?
Absolutely,
or do you need both of them to give you a signal?
No, either one.
So with either one, you are willing to intervene?
Yes.
And you will
now, in terms of in terms of a true drop in ejection fraction, strain, I might intervene. There's not a lot of evidence to support. There's ongoing study to evaluate whether we should be intervening on changes in strain. I tend to be more aggressive if I can, if there's enough blood pressure room. I don't know what your practice is.
Yeah, I mean, we're waiting for the SOCOR trial, and I think that
do you want to tell us non cardio-oncologist what the support trial is?
Sure, the support trial is basically, just in simple terms, and it's a clinical trial that is being run by my friend Dinesh from Canada and Tom Marwick, and basically what they are looking into if changes in strain are gonna really predict dropping ejection fraction or or worse outcomes in regards to cardiotoxicity. But because the data is still a little bit, most of this data, I think that has been supported by some what I call soft endpoints. And I think that we need more data in regards to hard endpoints on which it really matters, or it really moves the needle if we stop a potentially life-saving chemotherapy for an alternative, being guided by strain. So I think that strain, to me, is useful in certain scenarios, especially when there's a low or borderline LV systolic function, like in the 50s or 50 to 55. You look at the GLS, and if the GLS, is less, is more positive than -18, then probably there's something going on, and you have to consider maybe start anti-remodeling therapy. But I don't really 100% base my decision on if I'm gonna recommend stop or reconsider just by pure GLS.
Okay. So how do we? So now we detected them. How would we treat them?
Yes, that's a great question. So there's a lot of data that's been presented on cardioprotective treatment and also treatment. Treatment post drop in their ejection fraction. I think we use beta blockers, ACE inhibitors, and now ARNIs, just typical heart failure meds. There is data, and this was nicely reviewed in a paper in our journal by Dr. Monica Avila and her colleagues in Brazil, and this was a nice review on the role of cardioprotection and treatment, and she's certainly had done studies in this, and so she had the nice opportunity to review this. And so this slide shows you that the top one is we mentioned a lot, Dr. Cardinale. She's really done a lot of great work in this field. So her study, this is a little bit different. This is patients that had a positive troponin, randomized to enalapril. You see the difference in cardiotoxicity, dramatic. But the other studies are more prophylactic. So patients put on CoReg. This, small studies. Certainly in the combination of enalapril and carvedilol in this study by Bosch in 2013. These are fairly small studies. That was 201 patients that showed there was some benefit in prophylactically placing patients on enalapril and carvedilol.
But they're starting when?
Starting prior to therapy or concomitantly with therapy. It depends on which trial.
So you're talking about not waiting for a signal.
Just putting everyone on it.
Just
putting everyone on it.
Okay.
Yeah. And then there's other studies, that looking at candesartan and 2x2 candesartan and metoprolol. Interestingly, metoprolol didn't seem to have a benefit, so it may not be a class effect, or it may just be a size issue. It's not sure, but in terms of anthracyclines, certainly ARBs, carvedilol, bisoprolol. Look at Herceptin and HER2 antagonists, which we haven't discussed, but using lisinopril and carvedilol, it can be beneficial in small studies. And in Dr. Avila's study, they did the CESI trial looking at CoReg for all patients, and it didn't meet the primary endpoint in terms of ejection fraction, but there was a signal there in terms of a change in troponin, that the troponin rise was attenuated in the group that received carvedilol. So there's signals there in terms of cardioprotective medications. It's tough though, because patients are on chemotherapy. Some of them have nausea, then you're adding carvedilol and medications that cause nausea, and they might get hypotensive with some of them, or infected. And so it's not a strategy that I think is well established in terms of prophylaxis.
So if I hear you clearly, there are two potential strategies, right? Put the drug in the water and give it to everybody who's going to receive cardiotoxic therapy, which is something for the trial, or wait for a first signal, then start.
Yeah.
It sounds like those two strategies have not yet been resolved as to which one is best.
I think so, and I tend
is
to
there any ongoing prospective randomized trial that will take those two strategies and look at them for 4 or 5 years?
The one that I've seen was also again from Dr. Cardinale. Had one where she randomized everyone based on waiting for positive troponin, or just giving everyone, I think, an ACE inhibitor or an ARB. I think an ACE inhibitor up front, and they're really was not much difference between the two groups. So
a simpler approach would be put it in the water and give it to everybody.
It's simple. I don't know. It's expensive and side effects. I don't know if it's.
And I have heard that oncologists are not always happy with that because of the side effect profile.
That's right. I think so. The side effect profile is important. I think a lot of these patients, being very honest, again, they're going through multiple visits for chemotherapy. They're seeing a bunch of docs. They're not looking to have more office visits, with nothing against cardiologists, but they're not looking for more stuff to do. And if they're not eating well, they're losing weight, sometimes they are dehydrated, and these medicines can lower blood pressure. So it's not a simple thing to put them on this.
And beta blockers create fatigue.
That's
Absolutely.
right.
And they already have fatigue.
Yeah. That's right.
So it's not exactly an easy take this pill and you'll be fine.
That's right.
My philosophy is wait for some cardiotoxicity to develop, or if they're really high risk, like the HOPE trial patient, diabetes, vascular disease, or any other reason that they should be on an ACE inhibitor anyways, then I'll put them on. I don't know, Juan, if you have any.
I think this point is very important because these drugs are not well tolerated. If patients are dehydrated, or again, they lost weight, and maybe they're more prone to be hypotensive. Sometimes, even when it's indicated, they will not tolerate to up titrate to those clinical trial doses. So I think that you have to be careful, and I don't think this is a recipe for all. I doubt that will be a good strategy. I think I see more that we're gonna be a bit more sophisticated in identifying the high risk patient, and hopefully this is ongoing effort. All cardio-oncologists, we're kind of trying to figure out getting project collaboration, because it's important. We really have to nail down in certain therapies which is the high risk profile patient, because this is not like cancer patient. We use it as an arbitrary term, but it depends on the cancer, it depends on the drug, depends what toxicity. So a lot of collaborative work, and between cardio-oncologists, cardiologists and oncologists need to be done.
Absolutely.
So if I summarize what you guys have said for our audience, it sounds like both you guys at MD Anderson and us guys here at Houston Methodist, we have a similar strategy of waiting for a signal, not giving them routinely the drugs, waiting for a signal, and when we see that signal that suggests cardiotoxicity, then intervening with some therapy. And it sounds like our oncology friends would be happier with that too. And the patients probably would be happier with that too.
Agreed.
Okay, now if in the future we are able to have certain tests that tells us that Mrs. Smith has a 50% probability of having toxicity, then perhaps we would be willing to start Mrs. Smith very early instead of waiting for the signal. But what you're saying is that we still don't have that totally worked out.
I think that identify the proper high risk patient, and then have that patient be randomized. Because it's not like all comers randomize all comers to placebo versus prophylaxis. But you identify the high risk patient, then you have, because we have to randomize. I mean, otherwise, So I think that will be the way where the field really will find some light, some guidance there.
For now, wait for a signal and then intervene. The signal could be either the troponin I or a drop in cardiac function by echo.
And the one caveat I'll say is, instead of waiting for a signal, if someone's really a high-risk patient, let's say they've had a lot of anthracyclines before, or they have known heart failure, then there's strategies you can do to use cardioprotection in addition to considering those medications. But one is trying to use liposomal derivatives of anthracyclines if you're using an anthracycline, and then dexrazoxane, which is an iron chelator, which which is FDA approved for patients that have metastatic breast cancer greater than 300 milligrams history per meter squared of adriamycin in the past, and that can be used as a strategy to help protect the heart somewhat. And there's some controversy based on older evidence that I think has been pretty well debunked in terms of dexrazoxane causing increased risk of not having a positive response to treatment.
What do you think about that? Because I'm very curious, because I know that it's a concern for you guys, right?
I think earlier on it was a bigger issue. I think now that's faded. I think that if someone's a candidate for curative chemotherapy and they've had prior anthracyclines, I don't think there's a lot of concern that it's going to inhibit or protect the cancer cells from efficacy of the chemo.
Yeah. Good.
So when you decide to intervene, do you have a preference between the beta blockers or the ACE? Do you use them both together, or you try one first and then add the other one? What's your cookbook for that?
I try one first. It's dealer's choice, really, frankly. Dealer's choice.
So you flip a coin or whatever?
Yes, yeah.
So you use blood pressure as a guide. If somebody has a low blood pressure, maybe try the beta blocker first.
Yeah, it depends. I mean, the problem is metoprolol, as we showed in the slides, failed the trial, and even small trials. It may have just been a sample size error.
So carvedilol is
bisoprolol, but carvedilol is usually the one that I use, and ACE inhibitors.
So you start one first and then add the other. You don't try to together.
Yeah, no, we do it as well. We usually we try carvedilol and also lisinopril.
So I'm a skeptic. I don't believe any of this stuff. How do you prove to me that putting these drugs actually does anything? Show me the pudding.
No. I'm not advocating.
No. So you've got a signal, and now you started them on carvedilol and ACE and whatever. What's the proof that doing these interventions actually works?
There's evidence.
There's evidence.
I think we should share that with the audience too. I mean, what do we have that proves that is absolutely?
Let me look for in my.
That is not just our
hidden
opinion.
slides here.
No, it's not an opinion.
Look at, I don't know if this is projecting, but this is data from 2010 showing patients that respond to ACE inhibitors in beta blockers within 6 months, especially. This is what we alluded to in the beginning.
So these people, they all already had a signal.
They all had a signal.
They already had cardiotoxicity.
Yes.
And what this shows is how well they respond based on the timing of intervention.
Right.
Yes.
Okay.
Yeah.
Yeah.
So, all right. So I think, in keeping with the theme of drugs that can cause heart failure, we probably don't have time to discuss all of them. We did discuss, we'll skip HER2 antagonists for the interest of time. But I think there's a couple fields of drugs that I think would be important to talk about, a couple of classes beyond anthracyclines and HER2 antagonists. And Eric, I mean, these are, if you could tell us a little bit about these drugs here, what they mean for you as an oncologist and how they've changed the field for you.
Sure. No, it's been quite a privilege over the course of my career to go from a period where we had chemotherapy and that was it, to now having multiple other classes of anti-cancer agents that have very significant responses. So these TKIs they're oral medicines. They can be taken at home. They block certain receptors in cancer cells that drive growth. They have completely transformed a number of diseases, such as chronic myelogenous leukemia, and turned a number of these disorders into chronic diseases and we're not talking about months, we're talking about benefits for years and years. It's really made huge differences in melanoma, lung cancer, advanced lung cancer has been completely transformed just with these meds. Now, it's not that they don't have side effects. They can certainly cause diarrhea and skin issues, and in fact some cardiac issues. But the ability to use these drugs really has been one of the pillars that has led to such improved outcomes. VEGF inhibitors similarly block a different receptor, but similarly has really made substantial improvements in metastatic kidney cancer. So all of these drugs are used in advanced disease for the most part. It's not that they're being used in very early stage disease, but patients are often on them for a very long period of time, and especially the VEGF inhibitors can cause substantial hypertension over time, and that has got to be addressed, or because some of these people are on these medicines potentially for years, and you would hate to have to stop it for hypertension that's not controlled when their metastatic kidney cancer is controlled.
No, absolutely. And I think one thing we're learning is when these drugs first came out, we were told the incidence of cardiovascular events aside from hypertension, so heart failure, maybe 1%, maybe as high as 2% with some of these drugs. But as it turns out, as with everything, once you apply them, one is an issue of the terminology and definitions, but also the other is using it in real world with maybe a sicker population. So this is a nice study from Hall and colleagues out of Stanford from 2013, looking at some of these drugs and looking at the incidence of cardiovascular events. And so if you look at if you can see, I know it's hard to see this color blue. I'm partially colorblind, so I can't tell you what color blue that is. But you can see that the incidence of heart failure with some of these drugs is, for example, with sunitinib was as high as about 13%. And some of these other drugs, 7-8% when they were 1 or 2% when
But
they
any
were first
toxicity was as high
so
as 70%.
yeah, and that includes a lot of that's hypertension. So as Dr. Bernicker mentioned, hypertension is ubiquitous in these drugs, so it's really important. And some of this is associated with proteinuria, so there's a role for maybe considering ACE inhibitors or ARBs in these patients. But either way, just treating the blood pressure, because we know that long term that's going to increase the risk.
Decrease, 14%. That's
it's impressive.
That is not.
So this is one study, but it's the difference between this and the original studies. So it's important to be aware of it. And then another field that really has changed the field in the last few years. With Dr. Lopez-Mattei's colleague Jim Allison and others that have helped discover this immune checkpoint inhibitors. If you can tell us how that works and what that's done for your treatment options.
So immunotherapy does not work in everyone, but when it works, it tends to work quite well. These are intravenous medicines that interact. So to make a complex story short, T cells or immune cells can be blocked from action against a cancer cell. So that all of the T cells have on and off switches, and the cancers exploit the off switch and turn off the immune system. So these drugs, these checkpoint inhibitors, block the off switch. It is, again, completely transformed melanoma, lung cancer, a variety of other tumors. Now, it's often disappointing. Every patient I see wants immunotherapy, pretty much regardless of what stage of cancer they are. So I don't want to oversell it, but for example, with lung cancer, the leading cancer killer of men and women, people with metastatic lung cancer who used to essentially almost most of them be dead within a year, about 25% of them will be alive 5 years later. So we have a ways to go, but you can see from the plot just the explosion of indication and utilization. And the issue is it does cause side effects, not chemotherapy related side effects, but they can get pneumonitis, they can certainly get colitis, and they can get a variety of cardiovascular side effects.
Yeah, and so I think that's a good lead into, I know we want to save time for questions, so if I know we have a good case, if Dr. Lopez-Mattei can kind of walk us through a brief version of this case.
So we're going to do a brief presentation here. This was a 76-year-old man with squamous cell carcinoma, basically on a 4th round of treatment that included nivolumab, which is one of these immunotherapies. And the patient presented with bilateral lower extremity edema and dyspnea during the treatment, and then you see the EKG. On the top was the baseline, and the bottom the follow-up. And in the follow-up, all I want to point you is that there was a PR prolongation, and also increase in ectopy, in addition to his symptoms of heart failure. If you can.
And he had a high troponin.
And he had a significantly higher troponin, in the 400 range, which for a high sensitivity troponin T, that's pretty high.
That's pretty high.
So and you can see that this was the MRI that was done, and basically if you use the cardiac MRI criteria for myocarditis, basically you have in the left side. The left panel, you have the T2 imaging with increase in edema, and in the right hand side, you're gonna see the leg gadolinium enhancement in the infralateral wall. So this was consistent with myocarditis, and it was associated with the treatment, which is a complication that is not as rare as we thought it was. And at the same time, in our center, we basically try to do biopsy, and we try to do cardiac MRI on both, because it's a patchy disease, and there's a lot of work that is currently going on led by my colleague Dr. Nick Palaskas. But basically this patient was treated with steroids and did well, start decreasing the troponin, and the ejection fraction dropped, but eventually improve. If you go to the next slide, maybe we can see yes. So basically in the left hand side, you see that there's the normal LV systolic function. in the left side, and then in the middle you see that there was a decrease, and that's what when he developed the toxicity. But then the ejection fraction improved after steroid. If you click again, you might see the other ones playing. Maybe there's a little bit of a delay.
It's very hypokinetic because it's not moving.
Yeah. but believe me that it got better. But you know what the problem with this toxicity is, that the EF, 50% of cases it doesn't drop.
Yeah.
So you have to be very suspicious and then look at the troponin and then do a biopsy cardiac MRI to be able to get a good diagnosis.
Yeah. So I think
it did respond to steroids.
This responded to steroids and also a course of IVIG that we did as well.
And I think what's really important to highlight, I mean, even though in this case the biopsy was negative, but what you've shown and others have shown is the opposite, right? So your study here, the biopsies and MRIs.
So this was work led by Nick Palaskas, which this is really spearheaded by him, and we review the cardiac MRIs and the biopsies on these cases, and we found that there are some cases where you have a negative biopsy and positive MRI, and the clinical presentation is consistent with myocarditis. Yeah. So it's a patchy disease. Yeah. We have to be careful. Sometimes, I mean, we recommend to do both for now, and there's more things coming from our group.
Yeah, I'm anxious to see that, because if you look at myocarditis, lymphocytic myocarditis, usually with MRIs, highly sensitive and specific, whereas the biopsy is not so much.
Right.
But in the data that I've seen, the other data that we reviewed from the first reports, if you see here, the late gadolinium enhancement in one study was 23% of patients, the other 74%, a little bit all over the map, whereas biopsy was actually 89 to 100% diagnostic in these patients. So interesting. I think for these patients, it's sometimes it's hard to talk them into a biopsy when they're going through everything they're going through, as Dr. Bernicker knows. Wow. But it is something important to know that MRI might not give you the diagnosis.
Right. And that's another issue. And the other issue is that if it's too early in the disease, you might miss the MRI findings because it's too early and you cannot see it. And that's observation also that have been shared with Tom Neelan from MGH. So I think that that we're gonna hear more about how to diagnose this disease with the biopsy and other imaging modalities. PET also it could be an alternative. I think it could be exciting to have a really good PET tracer specific. So we'll see more things coming here. Yeah.
So we have about 10 minutes left. I would like to have some questions, and if we can summarize what we have done this afternoon, I think a couple of take-home messages. There are agents that are cardiotoxic. Jamycin, the one most commonly known by everybody. The early we detect a signal of toxicity and intervene, the more likely patients will do better than if we let them see weight, although our first case was seen late and still had some improvement, though not full recovery. The other take-home message is that a lot of the newer drugs that are saving lives also have their own possible toxicity, not only just myocardium, but also blood vessel, vascular, hypertension, thrombotic complications, and even myocarditis. So we have to be on the look for all these possible complications. So we're going to have some time for questions, and one question came up, which is almost perfect timing to where we were, is that many of our patients also receive radiation. Now, radiation toxicity in terms of the heart doesn't happen in the first week, first month, first year. It's a late event. So one of the questions that we're being asked is, A, if there are patient group that is at more higher risk for cardiac toxicity. Second, what's the advice we provide in terms of when to start doing some serial assessment, at which time, how often should we follow these patients, and what kind of imaging techniques might help us better detect the late toxicity from radiation. So who wants to take that one first?
Yeah, so that's a good question. So I mean, I think one thing is in terms of, one, there's a great review in to plug the journal by Andrew Farrick and colleague Gary Francis on radiation toxicity. So that I would guide you
go to the journal.
Yeah.
You can go on the website and read it, or if you received it, read it because that's a good review on that.
But to answer your question, I mean, we know that, I mean, a lot of it's dose dependent. So the higher dose you have and, you know, where you have it is very important. So for breast, I mean, we've learned a lot about techniques to kind of spare the heart field from the radiation field. So prone imaging and taking the breast out of the field as much as you can, and other techniques that have, you know, compared to 20 years ago, that have, you know, should try to minimize the exposure. We don't have a lot of long-term data to see what the results are, but we anticipate that there'll be less toxicity, certainly not zero. Screening is a different question. You know, really, I don't screen for patients unless they have symptoms. But we know that radiation toxicity can cause, you know, any part of the heart. It can cause pericardial disease, and that can be acute or late. Coronary disease is very common in these patients. Valvular disease, and then it can cause cardiomyopathy as well, and diastolic dysfunction. So I don't necessarily go looking for it, but if they have symptoms, you know, shortness of breath, and I'm seeing them in my clinic, certainly getting a coronary CTA or an angiogram if it's suspicion for.
So one of the questions that I have people ask me on the hall is like, you know, if they don't have a murmur, you probably don't have to worry about valvulitis. So, you know, don't do an echo if you don't even hear a murmur. But what about calcium score? Because there is some interest in perhaps these people having an accelerated rate of positive calcium scoring, and if you pick them up, perhaps then, obviously right now hypothesis because we don't have proof, but perhaps intervening with statins and other therapies might prevent the heart attack that may happen 3 years later. So, what's your thought on just doing a calcium score?
Yeah.
So yeah, I mean, if you allow me to say that there's actually some people looking at this. For example, there was a recent study by my friend Ron Blankstein and group where they basically found that in patients with lung cancer, I mean, there were exceedingly high incidence of calcium score present. And a lot of these patients were not in guideline-directed therapy. They were not on statin. In our group, we basically recently had a publication in the Journal of Cardiovascular Imaging where what we found was that patients that receive radiation, some of them will develop coronary calcifications sometimes within 1 year after radiation therapy.
1 year after?
Yes.
Well, that's an important piece of data.
So that's compelling. So we're looking at more data right now. I'm doing calcium score. We're evaluating about 270 something patients. I think that's the total number. Might be around there. But I think that we want to look at the risk, how calcium score behaves in this population of patients that receive radiation therapy. And also there's an effort in the SCCT society right now. We're kind of putting together a consensus statement on how to use cardiovascular CT in cardio-oncology, and part of that will be a section dedicated to the potential role of calcium score in these patients. So I think there's certainly there's a lot of interest in this aspect. I think calcium score right now I cannot recommend it because we don't know how calcium score behave in this patient. We know that what is out in MESA, but we don't know how they calcium score will predict outcomes in patients receiving radiation therapy. But certainly, you know, I think the important thing is more than 30 grades. I mean, there's a lot. The other thing is that at least follow up the patient at least once a year, because you know, because if everything is done, then perhaps maybe you can detect something, murmur, maybe do an echo, some symptoms. So I think you have to kind of try to not lose the patient follow up, and I think there's certain things that you can do, preventive treatment, you know, do the basics well, you know, the ABCDs, you know, the lipids. So I think those things are important.
So stay tuned.
Yes. So
stay
I think
tuned.
it's just.
But it looks like perhaps we might be talking of calcium scoring in another few years as a way of tracking these patients.
Yes.
Another question I will receive: what is the impact of comorbidities hypertension, diabetes, on development of cardiotoxicity. I guess we touched on that, but maybe we didn't make it that clear. Eric, you want to take that?
Yeah, I'll answer it briefly so we can get to the other questions. But yeah, it's incredibly important. These are risk factors that we know can contribute to cardiotoxicity. So you have to treat the hypertension and control the diabetes. Absolutely.
Yep. We have any other questions to look at? All right. Can you? Given the available data about endpoints, at what point does cardiotoxicity become severe enough? Oh, this is a big one. To consider discontinuing chemotherapy. Yeah. Boy, that's $1 million question. I think the only person that probably can answer that question is the person in the hot seat, and that is, yeah. So that is the most important and most difficult question to manage.
So briefly, if the patient's getting chemo that's theoretically curative, meaning it's early stage disease, high risk breast cancer, lymphoma, we'd be very hesitant to take them off and go to other therapies. So that's a lot of discussions with the cardiologist. You don't want to lower their chance of cure. Interestingly, patients with immunotherapy, where we're trying to get them into remission and maybe long-term survival, a lot of times if they develop cardiac issues or pneumonitis, even if you stop therapy, many of them stay in remission. So that's a bit less of an issue. If it's palliative chemotherapy and they're developing heart failure, that's a fairly straightforward thing. You're going to switch to therapy. So with curative intent, you'll bend over backwards to keep them on therapy unless your cardiology colleagues tell you have to stop.
And I'm sure you guys deal with that quite frequently, right? That's not an uncommon situation.
And it really requires, as you said, close collaboration. And for me, it's always calling the oncologist first, getting an idea of what their survival is with and without the drug, and then me trying to determine what their survival is from prognosis from the heart failure, and then us discussing, kind of whichever one seems to be the more likely role in their mortality. That's the one that's gonna win out.
So we're almost done with the hour. So I'm going to just ask one more question, and that question is kind of like one that brings us down to reality. All of us here are blessed working in top-notch tertiary care centers. So we get this question here: how can physicians in low-volume, small community environments be able to manage this complex topic that we have just discussed? What would be any advice that we give to physicians, oncologists, cardiologists in smaller communities that perhaps don't have access to all these things that we talked about? Who wants to take that one?
So I can take that one. Start at least. I mean, it's not an easy question, but I can tell you what we're doing in the Texas ACC chapter, Texas American College of Cardiology chapter. We have a Texas Cardio-Oncology symposium where basically our efforts are to educate the cardiologists of the community in regards to how to manage cancer patients with cardiovascular disease, cardio-oncology patients. So if you want to learn, we're gonna have our meeting is gonna be April 18. There's other chapters that are following that strategy. Like I recently spoke with people from the Indiana chapter. My good friend Vijay Rao and Ryan Daly, and they have a very good collaborative, and they're mostly in the private. It's more like a private group, but they're very interested and they take care of patients with cancer and cardiovascular disease. So they're gonna hold up also a meeting there in collaboration with the University of Indiana. So there are. I think the key is to educate the people, to make sure that there's enough opportunities for the cardiologists in the community to get educated about these issues, because part of it is having the curiosity. If the patient that you're treating has cancer, is getting treatment, you better know what the drug is receiving, because this is probably could be the culprit. So we have, I think that's the most important thing. Be curious. If you see that your patient is having some issues, is receiving cancer treatment, make sure that that you know what type of cancer treatment they're getting, or if they had in the past.
And Eric, your advice to the oncologists in those smaller communities?
They're doing everything they can just to wade through it. The bottom line remains that there's an overwhelming, huge amount of data that we're all inundated with. So it's got to be education, and I'll be honest, I think eventually there's going to be telemedicine. I think there's going to be communication with, say, cardio, oncologists in multidisciplinary groups in major centers. Because traveling in from a lot of these places for patients is too burdensome.
I think you have hit the nail on the head. For smaller communities, the ability to develop a relation with a cancer center, a cardiovascular center, and then use telemedicine might be the answer for many of these smaller communities. And with that, we are going to finish this webcast. Time goes fast when you're having fun, and we thank all of you for being a wonderful audience, and of course, I thank my panelists for a spectacular good job. So, good evening to all of you. Have a nice evening.
Thank you.
Keep talking.
So,
All right.